So a lot of advances that are ongoing with the options for patients with myeloproliferative neoplasms. I'm particularly excited about first trying to make inroads for patients with polycythemia vera. So there are new options that are potentially available. In Europe, there's the long-acting ropegulated interferon alpha 2B that in long-term data compared to hydroxyurea in high-risk patients with PV has been found to be both superior and potentially having a favorable impact in terms of allele burden. There was presented at the European Hematology Association meeting earlier this summer data with a trial comparing utilizing this therapy in combination with phlebotomy and aspirin versus phlebotomy and aspirin alone in low-risk PV patients, and seemed to have a significant benefit in terms of disease control and event-free survival. If this continues to hold up, this really could have a paradigm shifting approach to treating individuals with lower risk PV with medical therapy. Patients with myelofibrosis, there is, I think, the most amount of activity ongoing, and that's logical for a variety of reasons. Patients with myelofibrosis have the most severe forms of myeloproliferative neoplasia and have the greatest unmet needs, both in terms of disease burden as well as impact on survival. We've had now for many years, almost a decade, the approval of ruxolitinib that as a JAK inhibitor has been very impactful in improving splenomegaly symptoms and likely survival. We now have fedratinib that's been approved since September of 2019 that is indicated in both front and second line and is an additional JAK inhibitor that again can improve symptoms and splenomegaly.